Let's give Ed Simcox, the Chief Technology Officer at HHS, a round of applause. Ed, come on up.
Good afternoon, everybody. I'm what sits between you and the raffle of the 2019 Mustang convertible that DJ is so generously giving to one lucky person in this room. So you have to stick around. You have to be present to win. My name is Ed Simcox. I am the Chief Technology Officer at the US Department of Health and Human Services. I have been in federal service now for about 2.5 years. Before that, I was in industry, as we say, in the Beltway, meaning that I was in the health sector working in IT. And I've held multiple positions within healthcare providers, as well as with IT firms that service the needs of healthcare providers and insurance companies here in the United States. And so I'm very, very happy to be here today. This is what gets me energized. This is the best part of my job. The Secretary Azar at HHS is fond of saying that the Office of the CTO is kind of the front door for a lot of people to the work that goes on across HHS. I'm an attorney by training. Don't hold that against me. I'm a recovering attorney. I haven't practiced in a long time, but actually got a real passion for healthcare during law school. And seeing the good that can be done through advocacy and policy work. And I've always had a real appetite for policy and thought I wanted to be a tax attorney. And I had a mentor that was a tax attorney, and I went to work for the tax collection agency within Indiana. And I tell people it was the best job I ever had because I learned what I didn't want to be, which is a tax attorney. And so I set my sights on my second passion and my real passion, which is IT, and got involved in some startups that were doing some really neat things, early what we call telehealth work. And at that time it was radiology, it was teleradiology, and I was just absolutely fascinated with this idea that clinicians could see patients regardless of where they sat. And of course, today radiology is all digital, and there are night reading services where folks are working overnight, say in Hawaii or overseas, and able to perform their duties as doctors regardless of where they are, and that all has to do with technology. So that was really my first taste of IT and how it can benefit healthcare, and I haven't looked back since. So I want to tell you a little bit about our agency first. How many people, raise your hand if you either work for HHS or have worked for HHS at some point in your career? 2? 3, okay, great. I'm gonna give you some stats on HHS. These are the things that you probably don't know and are afraid to ask, right? So HHS is the largest civilian agency in the world. Largest civilian agency in the world. We have 11, it's actually what we call a cabinet level department. There are about 10 cabinet level departments within the government. That means that our secretary sits on the presidential cabinet and has cabinet meetings on a regular basis with the president and in the White House and the presidential staff, as well as the Domestic Policy Council and other parts of the White House machine. $1.2 trillion budget every year, okay? That is actually what makes us the largest agency in the world as far as civilian agencies are concerned. There are some defense and intelligence agencies that do eclipse us, but that is a staggering amount of money. Most of that money, of course, is part of the Centers for Medicare and Medicaid Services. We run the largest insurance plan, if you will, of any type in the world. Just to kind of put into perspective, so there are about 50,000 people that work at CMS, and United Health Group in their plan space, I believe, is up to about 200,000 people, and they serve a population that is large, but much less than what CMS serves. We have about 80,000 staff across HHS, and the large agencies that you're probably familiar with are the Food and Drug Administration, the Centers for Disease Control and Prevention, the National Institutes of Health, and CMS, of course. And then there are many other agencies in what we call offices or staff divisions, like the Office of the National Coordinator for Health IT. And any of you that deal with data or work within providers are probably aware of the stimulus funding that started under the Bush administration that was really around promoting interoperability of data, sharing data between systems sharing data with payers and with patients. And that work continues today. That's a relatively small office as far as the agency sizes of the agencies inside HHS. So the building that you see where it looks like an alien ship landed, this actually sits on the mall in Washington, D.C. This is headquarters. It's called the Hubert Humphrey Building, and it is the second ugliest building in Washington, D.C. Following very closely behind housing and urban development, which I think is hilarious. But if you've ever seen the HUD building, Google it. You'll know exactly what I mean. So I want to back up and tell you about the office a little bit. So here's the mission of our office. Our office is about innovation, catalyzing innovation, okay? Adopting emerging technologies, not only in the four walls of HHS, but also within the health sector writ large. And then data-driven problem solving. And the whole idea here is to reduce costs and improve health and human services for all Americans. Now you might ask yourself, how can innovation possibly be taking place in this building? I asked that when the first day that I walked in to HHS. I asked that as I was standing in line to get fingerprinted and get my badge. But I can tell you that innovation is alive and well. And my office is the heart of innovation at HHS. It's the center of innovation that spans across all of the agencies and offices that I mentioned. And here are the principles that guide us as we do innovation work across HHS. Number one, it's about open data. Open data fuels insight and change. When we talk about things like value-based care, when we talk about things like you all are talking about right now in Texas around Medicaid expansion, for instance, what's super, super important is that we operate on data. You cannot manage what you cannot measure. And a lot of times, the data is there. I have a mentor that is, he says, we are data rich and information and knowledge poor. Data rich, information poor. We're not getting enough information out of our data, and there are many reasons why that is the case. There are so many regulatory hurdles that folks have to jump through, for instance, just to release certain types of data. The HIPAA rules, for instance, are an example of that. CFR 42, Part 2, another example of that. So we do a lot of work and a lot of outreach and demystification, if you will, in the health sector around, hey, HIPAA, very important, but key in the name HIPAA, in the actual title, there's one word that we always forget. We're always focused on privacy and security of data, and we forget portability, right? The data must be portable. So our administration spends a lot of time on outreach. We've done everything from change the website of the Office of Civil Rights within HHS, and they're the ones that do the enforcement around HIPAA, to coming out with guidance on how to really thread the needle, meaning how to balance on the scale portability with privacy, and that's super important. And there's some great resources on hhs.gov to talk about that. Partnerships accelerate mission. The work that goes on in Washington, D.C. is fueled by innovation, and innovation typically does not come from within government. And you're hearing that from the head of innovation, me, today. It comes through partnerships. It comes from the rest of the health sector. It comes from us getting people coming into federal government, coming into federal service to do tours of duty to help us figure out hard, pressing problems, how to redesign insurance, how to liberate data, how to get drugs through the approval process faster, how to get medical devices and now software that acts as a medical device through the regulatory process quicker and efficiently, but also in a very safe and effective manner, right? Consumer focus drives better healthcare. I'm a big, big believer in this. If you study the consumerization of various industries, you look at if you look at the financial industry, it used to be that you had brokers, and you would have to call your broker, and your broker was an oracle of sorts or a wizard, and they knew all the information, and you didn't have access to it. And then things started to shift to the web, and then you had to pay for access to that data, but you could get the data. And now it's free. It's free to everyone, and so it really leveled the playing field for the consumer of investment products. Same thing is going on in healthcare. Same thing has gone on with IT. If you think about smartphones, smartphones were a great equalizer for consumers in many different ways, many different industries. And we want to see the same thing happen in healthcare. We believe the patient should be at the center of their care. They should be in control of their information, and they should be able to make their own healthcare decisions with that information in an informed way. So my office is very involved in that type of work, and we'll touch on a couple of the projects that we're doing in that area. So we have three in our innovation hub in my office. We have three different programs. We have data programs, we have internal innovation programs, and we have partnerships. And I want to touch on a few of these today. First, I want to hit data, the all-important topic. So my office, a little bit of history. So the office of the CTO at HHS was started under the last administration, the Obama administration. The first CTO was named Todd Park. And Todd was all about data. He was about liberating data within HHS and putting it to work. He was about giving data to academia, exposing data to scientists, exposing data to researchers that understand insurance, external actuaries, people that we need to be giving data to inform us on how to improve healthcare. And he did a great, great job at it. And today, because of his pioneering work, I'm proud to say that on healthdata.gov, which my office runs, we now have 3,000 different data sets available and published that you can go out to right now. You can grab that data and you can use it in your business, your practice, your research, your science. And we continue to move down that path. HHS, as a collective, has more data than any other organization on Earth, as far as we know. And again, I'll make a caveat that nobody knows how much data really sits in the intelligence community, but we have massive amounts of data. So just within CMS, in the production computer systems within CMS, we know that there are thousands of data sets. We haven't even cataloged all those data sets. And there's important stuff locked up in that data. There's knowledge and insight locked up in that data. So it's super important for us to continue to liberate that data and make it available to you all so that you can make informed decisions in your work. The second thing I'll say about data is that while we generate a lot of this data, it all has a primary use. Congress basically instructs us and pays us to do certain things, like in the National Institutes of Health. Maybe we're studying DNA in fruit flies, for instance, and this is a real thing, right? The DNA in fruit flies, all that information is locked up in a database, and the primary use of that data is super important. And Congress thinks so, the National Institutes of Health thinks so, and the scientists think so, the scientific community thinks so. But we have this idea of secondary use, so taking data and using it for something above and beyond its primary use. And that's where you take one data set and not only give it to a community that can better leverage that, but you combine that data with other data sets. And the insights that you can get from that data are exponentially more valuable in a lot of cases than than just the singular primary use of that data. So an example of us combining data, liberating data and combining data and using it for better secondary use is the Opioid Codeathon that we had. We had this in the Great Hall of that ugly building you saw, which is the big rotunda area. We had 45 teams of industry participants come into our building and create computer code, create apps for smartphones and computer code overnight. They brought data to HHS. We liberated a bunch of data, published that out to the community, all kinds of things. Some of the data that we had were things like ambulance runs, death reports from coroners, ED data about overdoses, and so forth. We also had a bunch of data from the Centers for Disease Control and Prevention and many, many other data sets. We made this available. We told people the data that would be available during this time. Come with your ideas. Help us solve the opioid crisis in the United States. And I'm happy to say that today, after doing that, we now have people in industry have created 10 software apps for smartphones as well as for websites that are now in production and helping us combat the opioid epidemic. We're using some of those apps internally now, and some of them are available to you, and I'll tell you about one of those. So Google came in with a team of coders. They had 3 coders, and again, they started on one day, and we had speakers, and then they began the coding exercise, the computer software programming exercise, and they went overnight. And then we had judging the next day. And Google came with, guess what? Their search engine and this thing they have called Google Maps. And I'm sure many of you are very familiar with that. They have these amazing platforms on which you can build other apps and you can layer data in to get better insight. What we did is we provided data such as opioid take-back site data. This is where you can go if you have leftover opioids in your medicine cabinet. You can drop those off, no questions asked, and it goes down a chute, and you walk away. And what we were hearing after looking at the data was, you know what, yeah, sure, I would turn in my opioids, but unless there's an actual take-back day at the local fire department or something, I'm not gonna really be able to search those sites out. Where are they? We don't even know where they are. So what we did is we got all the information of these take-back sites, the addresses of these things. They took their geographical data, their latitude and longitude data, and they mapped every single one of these addresses across the United States. And they did this overnight, in one night. And the next day, you could go into Google Maps or just go into Google and you could type in opioid take-back site or controlled substance take-back site, and it would immediately pop up the closest site to you. That's an example of how liberating data and public-private partnership working together can help solve the opioid epidemic collectively. I want to turn a little bit more to partnerships now. But first I want to tell you a story. So when I first became the Chief Technology Officer, the first invitation that showed up on my calendar was an invitation to go see a man named Chris Liddell. Chris Liddell is the Deputy Chief of Staff in the White House. He was the Chief Financial Officer for GM. He didn't single-handedly, but he was a big reason GM really turned their operations around after the last economic downturn. He was also the Vice Chairman of GM. He was also the Chief Financial Officer for Microsoft. So he has a very innovative mind. He understands technology. And so I went in with my pitch. I had a pitch deck, sort of like a startup would have. I'm a brand new CTO. I would put together a strategy, and I wanted to go in and kind of wow him with what I had to offer as a leader. And I was going through my presentation, and about 10 minutes in, he just shut the presentation, and he said, "Ed, this is great. I've seen this. This is great work. This is corporate innovation work. I no doubt, there's no doubt you're going to do great things, but I want to ask you something. How can you impact billions of dollars and/or millions of lives? Billions of dollars, millions of lives." He said, "You're in this big agency. You know, you're not going to be there forever. None of us are going to be here forever. I want you to take all your ideas and go back and think about that. And then I want you to think about all your work in the context of that." And that was a very striking thing, very striking thing. So I literally spent that weekend with a whiteboard, you know, looking at all the different programs that my office does and helps with. And we started to reprioritize. And one of the projects that surfaced that I want to tell you about today is a project called KidneyX. And I want to give you a little bit of background first. So Congress gave us a gift in the form of what we call public-private partnerships. This is where I don't have to put out an RFP or an RFI or an IDIQ, alphabet soup, on how we procure and acquire services and technology in the federal government. That's the typical, usual way you have to go about doing this. It's very difficult to partner with people in the private sector, unless Congress gives you an exception. In this case, they did. They created this law called the America Competes Act, and it allows for us to create public-private partnerships. It also allows for us to create prize competitions as well. So if you're familiar with the X Prize Foundation, which is an organization that it's a nonprofit philanthropic organization where high wealth individuals have donated money to certain causes through the foundation to try and solve pressing problems for humanity. One of the big things that they did was figure out how to send new rockets up into space, and some of the, if you're familiar with, I can't remember the name of the space, it's SpaceX. SpaceX was born out of the X Prize Foundation, right? So we took that model and kind of ripped it off. We said, how can, we have a problem to solve, and let me tell you about the problem. There are 40 million Americans today with some form of kidney disease. There are 700,000 people with kidney failure, or what we call end-stage renal disease. There are, and 5,000 of those 700,000 people are on dialysis today. 500,000, okay? Each one of those people has to go to a dialysis center 3 times a week. The cost, the taxpayer cost, your cost for dialysis out of the federal budget, it's 1% of the entire federal budget. So every dollar you give to the Treasury through tax, 1 penny of that is going to dialysis. The end-stage renal disease legislation was signed by President Nixon in 1972. And the idea was we need a way to help people that they have no other way to get help. So we're going to allow them to go on to Medicare early, if you will, right? So we're making an exception in Medicare for these people. And it was amazing. It saved a lot of lives. But the purpose was really to help people stay alive until they could get a kidney transplant. Because it's not a cure, right? It's a therapy. So unfortunately, what happened is we have seen very, very little innovation in this space. Dialysis has not changed hardly at all since 1972. And the reason is because the way we pay for it. It's because of group codes. So each visit to a dialysis center has a fixed cost, and the dialysis centers have to figure out how to insert everything they need to in that code, everything that they need to within that bundle payment. And so they can't inject innovation, even if we ask them to, even if they want to. And to make matters a little bit more complex, there are 2 major providers of dialysis in the United States. that occupy almost 80% of the market. So there's been a reduction in competition, and of course competition breeds innovation. So we said we have to figure this out. We have to figure this out. Half of those 500,000 people that are on dialysis today, half of those people will be dead in 5 years. So we created KidneyX. KidneyX is a public-private partnership. We raised $25 million in partnership with the American Society of Nephrology. And we are in the process of working with Congress to appropriate another $25 million for a total of $50 million. And we're hoping that over the next 5 years, we can do that same thing over and over again. So KidneyX is a prize competition. And we just had our first round of prizes. The first prize in KidneyX is called Redesign Dialysis. And what we're doing is asking for people that have good ideas around artificial kidneys and other renal replacement therapies, as well as biologics and pharmaceuticals to come to the table with their ideas. So the first prize was just surface ideas. We want to hear from the health sector about ideas out there. The whole idea here was to create a new innovation community around this pressing problem where it really hadn't existed before, and also to begin to de-risk the investment environment for these new technologies, to say to the investment community that the US government is interested in seeing innovation make it into the commercial pipeline associated with treating people that are on dialysis. So Redesign Dialysis is the first prize. After that, we're moving upstream. We want to talk about prevention. We want to talk about detection. So we just gave out our first award for these great ideas. We gave out 15 awards of $75,000 apiece. The next phase is going to be what we call proof of concept, and this is for people that actually have ideas that they've begun to actuate and put into practice in a proof of concept phase. And finally, the third part of that will be at the actual commercialization of these technologies. So we're going to have 3 stages of prizes. In the meantime, I was talking about how important it is to always put the patient at the center of everything we do. Once we got started on this, we started talking to a lot of patients, and they said, we have ideas too. We're not scientists and inventors and engineers, but we have some great ideas. And so we decided it was imperative for us to create another prize. So we now have a Patient Innovator Prize as well. And if you know anybody that's been on dialysis and had to sit in the chair for hours on end, you know some very, very innovative and inventive people. And we've already seen, we just announced the prize. We haven't put out the call for the papers yet, but we know we're going to see some amazing things come out of that prize as well. So that's an example of public-private partnership. We think this is a model for the future. Really, we're looking at using this prize model for many, many different things, including looking at new payment models. So more to come on that. Startup days. I told you that we're a big part of the outreach at HHS. And what startup days, I'll tell you another story. When I came to Washington, I found it kind of interesting that as the CTO, I would sit in my office and I would get requests to meet, and almost invariably those requests would come from lobbyists, attorneys, and former members of Congress. No offense, lobbyists and attorneys and former members of Congress. But I said, that's crazy. We're supposed to be the front door to HHS, and people feel like they have to come to us that way. I mean, our phone number's published, my email's published. I don't understand that. And I thought back to when I worked at AT&T, and I worked with startups that were trying to get things through the FDA process, and they were working with AT&T because they were networked type devices. So think about a continuous glucose monitor that needs to use cellular service, cell phone service to be able to get telemetry data, up to a computer system in the cloud, for instance. And these are the types of companies that we were working with. And invariably, they would come with these amazing ideas, and you would ask them, what is the hardest thing in your business? And they would say, well, the hardest thing is trying to figure out how to maneuver the FDA process. The hardest thing is trying to get investors interested in me, interested in this product. We talk to these investors like, this is amazing, but we're not getting any money, because the investors would say, I'll tell you what, get through your first round of trials, come back and talk to me. And that's very difficult unless you already have a lot of money, right? So that's the whole idea behind Startup Days. Startup Days are meant to demystify HHS, put a human face on HHS, come into communities like this, come into rooms like this. I give a keynote, and then all of the leadership from our major agencies give lightning round talks of 20 minutes apiece. And they, from the FDA, for instance, we'll have somebody from the FDA come in, and they'll talk about how to maneuver the regulatory process, how to get started. They'll offer tutorials and materials and things like that. They'll talk about special pathways through the FDA. They'll talk about the connectivity between FDA and CMS as far as getting the dual approval that most things need, so that you can get paid for those devices at the end of the value chain once you commercialize your product. So we have the lightning round talks, and then at lunch we sit at tables like this. We have tent cards. And the folks in the room can walk up and ask any question. Nothing is out of bounds about the work that goes on at HHS and how we can help them. And it's been fantastic. We've done 12 cities. I think we're up to close to 2,000 people that we've touched with this program. And again, the idea is to demystify HHS and our agencies, as well as de-risk the investment environment for those innovators that are desperately looking for ways to commercialize what they're doing. So that's a little bit of an overview of HHS for you today, and what we're doing around technology and innovation. I would just leave you with a couple things. I guess I would leave you with a call to action. And the call to action is, when you go back to your provider organization, when you go back to your payer organization, when you go back, if you're an advocate, a policy advocate, when you go back to your advocacy organization, be curious about what your organization is doing with data. Start asking people, have you been out to healthdata.gov? Have you pulled down anything that can inform our policy work? When you think about Medicaid expansion, how do you make it more justifiable? What data are you using to make it more justifiable? Don't operate just on anecdote. Operate using that data. Derive information and wisdom from that data. And it's hard. There is something called data science for a reason. And there's a scientific process that can actually be applied to using data to solve pressing problems in our healthcare system. So thank you very much for sticking around today. And like I said, DJ will be raffling off a Mustang here shortly. And I don't know, do we have time for questions or?
Let's give him a round of applause. And I should say, it's very kind of you to donate your personal Mustang to the.
I thought it was yours.
Have a seat. We'll
Sure.
spend a few minutes.
Yeah.
One question I had that I'd like you just to sort of expound on is the Blue Button initiative, the Blue Button 2.0 initiative that your office is involved with, along with other folks. And I think this is one of those things that you touched on. You talked a lot about unleashing data, but it is one of these things that could have significant impact on the market in ways that the market doesn't yet know about. So explain in as simple terms what that is.
Sure. So Blue Button is something that we're running out of CMS, and to break it down into its simplest terms, what we're attempting to do is put claims data, a patient's data, back in their hands so they can use that data to make informed decisions about their care and begin to understand what's going on in their healthcare process. That's at its simplest. It actually started out as just a static file, if you will, that you couldn't put into an app on a phone or anything. Think of a fax, if you will. If you know what a PDF is, it was a PDF. It was a PDF. So then Blue Button 2.0, what it did is it took some emerging technology standards. It's called, the main standard that it uses is called FHIR. You don't have to worry about what that means. What you need to understand is that now what we're able to do, a patient, a member, if you will, is able to, in real time, get access to their claims data in a way that they can consume it. So it doesn't look like an EOB, for instance. It's going to look like, very user-friendly. So you can begin to imagine applications being written by independent organizations that take this information and can actually present a longitudinal record of everything that's happened to that patient over a given period of time.
I think the nuance there that you touch on, but which is so interesting to me, is that it's going to be, it has released this data and basically allowed developers to start writing apps to provide some utility for that data or to consumers, right? I
Yes.
mean, like, it's one thing to say I can go access this data. I'm not going to do that. I can barely figure out how to make an appointment with my doctor, right? But I'm on my phone all the time. And if there's an app that just sort of does all that stuff for me, that's a technical term. It's a loose term, but if I can pull down all of my data in a couple of apps that are targeted to me because some developers have figured out a business model, a few years from now, that seems pretty impactful, right?
Yeah, so we have insurance companies that are putting out apps. We have providers that are putting out apps. We have advocacy organizations that are putting out apps on this platform. And so if you, so the way that this works is if you're familiar with downloading an app from the App Store, the Apple, the iTunes App Store, or the Android App Store, that is the platform that we're using. So you come into a special development environment within CMS, you write your app, CMS blesses that app, and then you can publish it to the App Store, and you get real-time automatic connection to that data.
Yeah.
So this is just the first step in the Blue Button journey, to be honest with you. The next step is what we want to do is we want to make this data available to clinicians so that they can pull that information up in the context of the patient record at the point of care. And what we've heard from the provider community is how powerful that could really be to give a better 360 view or a longitudinal view of what's happened with that patient outside of their practice or outside the four walls of their hospital, where they already know that portion, right, through the medical record data that they have. But this claims data can actually lend a lot of more visibility into what's going on with that patient. And the whole idea here is to begin to reduce duplicative tests and help patients quicker and create more patient value and safety.
Yeah. I want to make sure we have time for your questions if you have them. There we go. See a hand go up. Just tell us who you are and who you're with, sir.
John Sapansky with Apex Primary Care in McAllen, Texas. Appreciate you being here, and I just had a quick question for those who are wanting to try to get a product approved through the FDA. What is that? What would their first step be as far as contact? I see you had some contact information there, but if somebody's trying to get a product approved, what would they do?
Is it a medical device? Is it a pharmaceutical?
Medical device.
Medical device.
Technology.
Yeah, so there are two offices at the FDA that you're going to want to probably get in contact with, and I'd be happy to sync with you afterwards and get you in contact with them. Yeah.
Great.
Thank you.
Other questions? I know we're short on time. I want to just ask one quick question. We all have medical record or electronic medical records now, in significant part, or many people do, in significant part because of the investment and the directives under meaningful use. Mm-hmm. That is a federal action, congressional action implemented through HHS. Is there stuff that you think that maybe HHS learned about that? It just feels like there's so much money sloshed around in that industry for a while, and a lot of maybe a little more marketing than substance in some of those enterprises. What have we learned from meaningful use that we can know to not do the same way in the future?
That's great. So one of the things that my office does is promote failure. We have this saying, fail forward, fail fast. This wasn't a fast failure, but it's an example of well-meaning, well-intentioned lawmakers, policymakers, adjudicators within the federal government saying we need to digitize healthcare. It was the largest industry, if you will, and the last to really digitize. So that was the whole idea, behind the meaningful use journey, right? Was to get things digital. But in the process of doing that, we left something out, which was the interoperability. We sacrificed interoperability at the altar of kind of this brute force digitization process. So now we have 98% of all hospitals on digital systems, but we don't have really good interoperability, right? So now we're aiming to fix that, and we're moving very rapidly that way, and that's why the 21st Century Cures Act is so important.
Yeah, that bill, as we discussed, one of the most important pieces of healthcare legislation in recent years that nobody's heard of, but it's super, super important. Ed Simcox, Chief Technology Officer of US Department of Health and Human Services. Sir, thank you very much for sticking around and being with us. Let's give him a round of applause.
Thanks for having me.
Yeah, appreciate it. Thank you.